This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse.
Welcome back to Audible Bleeding, and happy holidays to all our listeners. I'm Jacob Schwartzman. We are excited to bring in the new year with the latest Editor's Choice articles from the Journal of Vascular Surgery, and for that, we welcome back a familiar voice, Dr. Peter Gloviczki. Welcome back to the podcast, Dr. Gloviczki.
Hi, Jacob. Happy to be back. And let me start out by wishing a happy new year to all of our listeners.
Thank you very much. Let's jump right in. The first paper this month is titled Transabdominal Open Abdominal Aortic Aneurysm Repair is associated with higher rates of late reintervention and readmission compared with a retroperitoneal approach by Dr. Deary and colleagues. This is the CME paper of the month, and additional information regarding the CME is available on the JVS website. This is a retrospective analysis of 1,282 patients in the Vascular Quality Initiative undergoing open abdominal aortic aneurysm repair, either transabdominally or retroperitoneal, from 2003 to 2015. VQI data was linked to Medicare claims data to provide information on long-term follow-up. Patients with aneurysm rupture or supraceliac clamps were excluded. At baseline, patients with a retroperitoneal approach had higher rates of suprarenal clamps and concomitant renal procedures, suggesting more complex aortic pathology. By contrast, patients with transabdominal approaches were more likely to have iliac artery aneurysms and therefore were also likely to have anastomoses to the femoral artery. Reinterventions and readmissions happened more frequently in the transabdominal group, 42 versus 34%. This was primarily driven by higher rates of abdominal wall reoperations, 13 versus 6.1%. This remained true after adjustment for baseline differences between the groups using Cox regression modeling with a hazard ratio of 1.4. Other postoperative complications, 30-day mortality and long-term survival, did not differ significantly between the groups. So, Dr. Gloviczki, what does this paper add to what we already know about this subject?
Well, it adds a little bit to it. It tells us exactly what the conclusion of the authors is, that transperitoneal repair has more late reinterventions and readmissions than retroperitoneal repair. We always had controversy about how to evaluate the difference between retroperitoneal and transperitoneal repair, and there were papers that clearly showed benefit of the retroperitoneal repair. There were other papers who did not confirm that unanimously. It's obvious that patients with a hostile abdomen benefit from retroperitoneal repair. We know from the earlier studies that very likely patients with retroperitoneal repair have earlier return of bowel function, have less respiratory compromise, and the patients leave earlier. I think this paper looked at 5-year data, but we also, have to read between the lines, and we must understand that the way these data are collected, it's a combination of VQI data, which has a 1-year follow-up, and then these patients were linked to the Medicare administrative data. So you are not 100% sure about the coding, you are not sure whether all the relevant events were captured. On the other hand, some events that were less frequent, like less than 3%, they were completely disregarded. So I would say people who do transperitoneal probably even after this will go and continue to do transperitoneal, and those who do retroperitoneal exposure probably continue to do retroperitoneal exposure. And even if some patients are routinely operated transperitoneally, there are patients, clearly those with horseshoe kidney or those with a hostile abdomen, who actually can only be well operated through the retroperitoneal approach.
The authors actually cited familiarity with the transabdominal approach as a potential reason that some surgeons prefer this method. Do you think that with training continuing to move away from open and towards endovascular repair, that this problem will become exacerbated in that trainees will be less familiar with retroperitoneal approaches and therefore favor transabdominal approaches by default.
I think you are absolutely right, Jacob. I mean, that's what's going to happen. And not only the trainees, even the surgeons. The surgeons will do less open aortic surgery, and they want to focus on one technique rather than switch every time. And I don't think that just because there are more late incision-related reintervention in this paper, they necessarily are going to change the technique. But it will clearly be more and more difficult in the future to learn both techniques well.
Well, thank you for that informative discussion of this first paper. We'll move on to the second one. This one is titled, Fenestrated Endovascular Aneurysm Repair is Financially Viable at a High-Volume Medical Center with Positive Hospital Contribution Margins and Physician Payment by Dr. Chow and colleagues. This is a single-center retrospective review of clinical and administrative records at the University of Washington Harborview Medical Center from 2007 to 2017, comparing profit margins from endovascular, so either Cook Zenith fenestrated or physician-modified endografts versus open aneurysm repairs. Records were examined from 3 months prior to surgery up until 12 months after surgery. Outcomes included the contribution margin, which was defined as total reimbursement minus direct costs, and operational margin, which is the net revenue minus the indirect costs. A total 228 patients were treated with fenestrated EVAR. Of those, 157 were physician-modified and 71 were ZFen, compared to 21 patients undergoing open surgery. FEVAR procedures yielded a total contribution margin of $2.6 million over the study period, of which 90% or $2.4 million was from the index encounter. Per patient, the index encounter accounted for $10,500, significantly lower than for open repair, which was $21,200, owing largely to differences in reimbursement for the two procedures. Over time, there was a shift from negative margins for the physician-modified endografts to positive margins after the start of the IDE trial in 2011. And physician payments in the post-IDE era were similar for ZFen and open repairs and slightly lower for physician-modified endografts. And those numbers are $7,600 versus $5,800 per procedure. So, Dr. Gloviczki, the study goes a lot into the details regarding the various costs associated with fenestrated aneurysm repair. What do you think are the most important take-home points from this paper?
Well, the endovascular stent grafts that we use for the endovascular repair are expensive. And we know it from other studies that even for infrarenal abdominal aortic aneurysm repair, the cost of the graft determines that patients with endograft treatment may lose money versus open repair. And there is clearly a danger that in many institutions, fenestrated endovascular aneurysm repair is a financial problem as well. This paper clearly tells us that if you don't have an IDE for a physician-modified endograft and you use a physician-modified endograft, you and your hospital will lose money. This paper is by a very experienced group, and they have an IDE for physician-modified endograft, and this paper clearly shows that reimbursement and physician payment only increased after approval of the IDE trial for the physician-modified endograft. Fortunately, there was a new technology add-on that increased reimbursement for the ZFen graft, but still the average contribution margin for fenestrated grafts is about half of that of open repair. There are a lot of reasons, but the fact is that endovascular repair, especially fenestrated endovascular repair, although financially viable, it is still a more expensive procedure than open surgical repair.
One of the things that I found interesting, the authors noted that this was a high-volume aortic center performing these procedures, and that as a result, the findings may not be generalizable to smaller hospitals. What do you think about this? Should vascular surgeons in the community still use the results of this study to guide their practice? And do you think that the results would be different when the results are generalized to centers that are less high volume?
Well, again, the group of Dr. Starnes is a very experienced group, and it took them a while to make this procedure financially viable. So I have to agree that these procedures very likely should not be done in smaller hospitals. And physician-modified endograft, certainly according to the FDA, should not be done without an IDE. So I would say these are procedures that should be performed for appropriate indication by centers of excellence, certainly in aortic centers where both open and endovascular treatment for complex aortic aneurysms is available.
One of the concerning findings also that the authors mentioned was that if you account for indirect costs, not just the direct costs, and look at the total operating margin, it was negative $1.9 million over the study period. And while this improved in the post-IDE era, do you think that surgeons should be concerned by this finding, and are we going to start getting pressure from hospital administrators as a result?
Absolutely. I think these are very expensive procedures. And when we break down the costs, we see first that the endograft is extremely expensive. Looking back in the last 20 years, I have not seen myself any decrease of the endograft prices. As a matter of fact, I've seen increases. So I doubt that the endografts are going to be less expensive. So I don't think we can decrease expense there. But the only thing we can do is that with more experience, we are going to shorten the operating time. We are going to have a better patient selection. We are going to decrease the necessary instrumentation that we use for these patients. And that's why aortic centers where these procedures are done in larger numbers are going to be able to do fenestrated endografts, and they can afford financially to perform them.
Our next paper is titled Nationwide Comparison of Long-Term Survival and Cardiovascular Morbidity After Acute Aortic Aneurysm Repair in Patients with and Without Type 2 Diabetes by Dr. Tcarr and colleagues. This is a retrospective study using the Swedish Vascular Registry to identify patients undergoing ruptured or symptomatic abdominal aortic aneurysm repair, and also linking data with the Swedish National Diabetes Register to identify major adverse cardiovascular events. The authors used propensity score adjusted analyses to compare long-term morbidity and mortality rates. 363 patients with diabetes and 1,854 patients without diabetes were identified. Rates of repair with EVAR were similar, 41% of diabetic patients and 38% of non-diabetic patients underwent EVAR as opposed to open. Similarly, the rates of repair for rupture did not differ significantly between groups, so 62% for the diabetic group and 67% for patients without diabetes. In adjusted analyses that took into account many slight differences between the groups, the authors actually found that patients with diabetes had lower total mortality with a relative risk of 0.75 and also cardiovascular mortality with a relative risk of 0.17, despite having no differences in major adverse cardiovascular events, acute MI, and stroke rates. Subgroup analyses looking at patients undergoing open surgery still showed a significant benefit in favor of patients with diabetes for both total and cardiovascular mortality, whereas with EVAR we only saw this with cardiovascular mortality with a relative risk of 0.21. So, Dr. Gloviczki, we're always taught as medical students and residents that diabetes is bad, and here we are seeing that it's actually protective in patients undergoing abdominal aortic aneurysm repair. Should we be surprised by these findings at all?
Well, I think we should be surprised because we know that diabetic patients grow their aneurysms slower and maybe diabetes protects from aortic rupture. But here we are talking about different things. We are talking about cardiovascular mortality and total mortality at an average of 3.9 years after the procedure. So it is not easy to explain why diabetic patients who in general have higher cardiovascular complications would have a lower total mortality or lower cardiovascular mortality. Diabetes is a hot topic. The beneficial effect of metformin on aortic growth correlates to our attention to diabetes, and maybe we find a technique or a medication to decrease aortic growth. But it is not easy to explain why the protective effect of diabetes on the aortic wall affects mortality of diabetic patients after acute aortic repair. I'm always suspicious a little bit when studies lump together symptomatic aneurysm with ruptured aneurysm because in my clinical experience, these are two quite different group of patients with a significant difference in morbidity and mortality, because patients who have symptomatic aneurysms have a clearly and statistically lower risk of mortality and morbidity than ruptured aneurysm patients. And in this study, the entire study actually includes these acute aortic aneurysm patients, but the SWEDVASC registry and the Swedish diabetes registry are very important registries. And these are patients that is very difficult to study in a prospective randomized trial. So there was no doubt in our reviewers' mind that this is an important paper and we should include. But I have to tell you, it is not easy to explain, especially in patients who undergo open repair. If the patients undergo endovascular repair, you can explain that if they have delayed mortality, that might be because of sac rupture or sac enlargement. And then you can explain, well, there it is. Diabetes protects from delayed rupture or sac enlargement. But it's hard to say why this would happen in patients who undergo open repair. So I think there are quite a few open questions that come up in everybody's mind after reading this paper, and it is not easy to explain.
I agree. This is definitely not what I was expecting to read when I started reading this paper. One last question about this paper. 61% of patients in this study underwent open repair, which suggests a higher level of familiarity with this approach, or a tendency for Swedish physicians to favor this approach for whatever reasons. Do you think this limits the generalizability of this study to the United States?
Well, certainly our practice has changed considerably with elective repair, and it continues to change considerably with open repair. And in our VQI studies, we see considerable decreased morbidity and mortality of ruptured aneurysm repair when it is done endovascularly. So clearly, this is very likely not the finding that we would find in this country if we studied aortic aneurysm patients that we operated within the last 5 to 10 years.
Our last paper is titled Contemporary Outcomes After Carotid Endarterectomy in High-Risk Anatomic and Physiologic Patients by Dr. Rao and colleagues. This was a retrospective analysis aiming to establish outcomes for CMS physiologic and anatomic high-risk patients undergoing carotid endarterectomy and compare them to normal risk patients undergoing the same procedure. Patients were identified in the ACS-NSQIP vascular targeted module from 2011 to 2017. Patients were grouped by the presence or absence of symptoms, as well as normal risk, high anatomic risk, or high physiologic risk based on CMS definitions. 21,000 normal risk patients were identified and were compared to about 1,300 high-risk physiologic and 2,800 high-risk anatomic patients. Both high-risk groups had higher rates of symptomatic patients compared to normal risk individuals. Overall, high-risk physiologic patients had higher risk of stroke, 3 versus 1.9%, death, 1.9 versus 0.6%, or the combination of the two was actually double, 4.6 versus 2.3%. And in high-risk anatomic patients, they were more likely to experience stroke as well, 3 versus 1.9%, death, 1 versus 0.6%, or both, 3.6 versus 2.3%. Also, not surprisingly, cranial nerve injury was more common in high-risk anatomic patients at 4.3 versus 2.5%, whereas this finding was not observed in the high-risk physiologic group. The stratification of the study groups by indication, i.e. asymptomatic versus symptomatic carotid stenosis, yielded similar results. So, Dr. Gloviczki, this study clearly appears to justify the existence of the high-risk anatomic and physiologic criteria as outlined by CMS. How do you think we should approach these higher-risk patients given what we know about their risks from this study?
Well, this is an SQIP study, and we all know that these are 30-day results, and that's how we should interpret the data. And the physiologic high-risk patients have congestive heart failure, have an ejection fraction of less than 30%, or they have unstable angina and recent MI, while they count anatomic criteria as contralateral carotid occlusion, prior carotid endarterectomy, so the patient presents with recurrent stenosis or has a radiated neck. Now, it was good to see that in symptomatic patients, even if they were high risk, the 30-day stroke death rate was within the recommended 6% by the SVS guidelines. But it was disappointing to see that asymptomatic patients had a 30-day stroke death rate of 4.7%. Those asymptomatic patients who were of high physiologic risk. So that is not only higher than the recommended 3%, but one wonders if it is not an unacceptably high stroke and death rate that questions the appropriateness of carotid intervention in this type of patients. We know that medical treatment has significantly improved in asymptomatic disease. According to some studies, the risk of medical treatment and the risk of stroke and death in patients with medical treatment can be as low as 1% per year. So one wonders if any procedure is indicated if the stroke and death rate is 4.7%, or one wonders if patient selection was appropriate for a significant number of patients in this study for a procedure, since they were high-risk patients with an asymptomatic disease.
Sounds like we would need further studies with that specific population in mind, given these findings, especially since they're, like you mentioned, so far above the 3% stroke and death rate as recommended by the SVS. And as you mentioned, we should maybe be switching to medical management in these patients. What about Tcarr in these high-risk patients? Do we know enough about the risks to consider this as a possible alternative?
I don't think that we have data to really recommend Tcarr for high-risk asymptomatic patients. I think the Tcarr data look very good, and in the VQI study, they clearly look better than transfemoral carotid artery stenting. But I think at this point, we should prove that Tcarr is better than transfemoral stenting, certainly in symptomatic average risk patients. And I don't necessarily think that we have enough data to suggest that this should be the procedure of choice for asymptomatic high-risk patients.
So one last question. This paper kind of puts us as vascular surgeons in a difficult situation. If a patient came to you tomorrow and they were asymptomatic, but they were high risk physiologically, what do you think vascular surgeons should be offering these patients given the data that we do have?
Well, I think there are NESQIP data, there are institutional data, and there are individual surgeons' data. I believe that surgeons who do carotid procedures or interventionists who do carotid procedures, especially in high-risk patients, should have enough experience that they can tell the patients their own experience and their own 30-day stroke and death rate, and they should proceed accordingly. I believe that VQI data or NSQIP data is a spectrum of data that includes excellent centers and that includes average centers. And we know that when we look at the regional distribution of the outcome in VQI patients. So clearly we should tell them that this is the national experience, but we should also tell the patients what our experience is and recommend the procedure accordingly. But clearly we should be careful to recommend a procedure to a high-risk patient, physiologic or anatomic, who has an asymptomatic disease that is not a clearly threatening asymptomatic lesion with a pending stroke.
Dr. Gloviczki, thank you very much for this informative discussion. We look forward to continuing this collaboration again soon and look forward to having you back on the podcast.
Thank you very much, Jacob. I echo the sentiments of the editors of the Journal of Vascular Surgery, specifically Dr. Laurent, with whom we do this podcast, that we believe that it is a great way to reach out to those people who listen to podcasts. And I hope that this group is increasing as they hear about your productions through social media and other sources, and we are looking forward very much to working with you in the future.
Thank you, Dr. Gloviczki.